Hello and welcome to today's webinar, Intelligently and Virtually Managing Social Determinants of Health. Before we get started, I'd like to review a few brief housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the handout section at the bottom of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. You may ask a question any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen. We're very fortunate to have with us today from CareCentrix, Melissa Carr, General Manager, Home Services, and John Terenzetti, Vice President, Data Technology and Transformation. Also joining us is Ashish Shah, Co-founder and CEO of Dina, formerly Prepared Health, and Krupa, Srinivas, Quaint, and co-founder of Owned Outcomes. At this time, I'd like to turn the floor over to Melissa.
Thank you. And good afternoon or good morning, depending on where you are in the country. I hope everyone is having a wonderful day. At CareCentrix, our goal is to create a world where patients can heal and age in the home. And I'm privileged to work with this great panel every day to deliver on that vision. So really hope that you guys will find this conversation useful as we discuss how to best address non-clinical or social determinants of health needs of patients to help them heal effectively, either in a home or in a post-acute setting. So what are we going to cover today? Just provide a quick overview of the role of social determinants of health, why they're so important, why has it been such kind of a buzz phrase of the last couple of years, how we go about identifying, pinpointing the needs of certain patients, how do we identify kind of patterns where we could be more predictive of who would need what services. Again, then number 3, how we really create that as part of an operation. How do we make it scalable so that we can fully and successfully manage the social determinants of health? And then 4th, how it ties back to results. But before we get into the meat of our presentation, we're going to start with a poll. So quickly, I'll get you started, but where is your organization in terms of managing the social determinants of health? Okay, start to see some answers coming in. Okay, give a couple more seconds, we'll close this out. Okay. So when I look at the results, they're pretty mixed, pretty evenly split between near-term plans to implement a pilot program, have implemented a pilot program, or up and running with a fully integrated plan, which is great to see. We gave a similar presentation on this topic. Not a similar presentation, but we gave a presentation on social determinants of health a year ago, and there were a lot more in the aware but have not yet taken action category. And this is really what I would have expected. There's really been an explosion of headlines, press over the last several years around social determinants of health. And what we've really seen as we've kind of moved from 2019 into 2020 is that there's really more of a movement from just talking about social determinants of health to taking action around social determinant of health or non-clinical needs. We've also seen an explosion of social determinant of health technology companies that have really sprouted in the marketplace to help really address these needs. And it's really, I think, an identification or just recognizing the importance of taking action as the need to connect hospitals, doctors, payers, and community-based organizations in a scalable manner has never been more important to address the healthcare crisis in the country. And I do think that, you know, in the world, as we move outside back from the world of COVID-19 and start to reopen, some of those things become even more important than ever. And there's also been a huge catalyst in moving social determinants forward and expanding the role of addressing social determinants of health, as there's been an influx of value-based arrangements. And I think that's another pattern that we'll really continue to see take hold and get a lot more momentum over the next couple of years. And correlated with that, we're also seeing bigger investments are being made by plans, provider organizations, and hospital systems to implement the programs and infrastructures to support the holistic needs of these patients. So that's just a high-level kind of qualitative setup. Now I'm going to turn it over to Krupa to really dig into more of the numbers behind why social determinants of health are so important.
Thank you, Melissa. I'm actually going to switch back to the previous screen briefly. You hit the nail on the head when you touched upon numbers, because numbers is what I do. I look for patterns in data. And that being said, maybe I'll just ask the panelists very informally, hey, you know, what percent of health outcomes do we believe are influenced primarily by care that's provided in a healthcare setting?
Krupa, this is Ashish. I'll go first here. You know, I think when we take a look at just what's happening in the market and our own personal experiences, you know, I would say that there's close to, I would guess, a 75-25 split, 75% really being influenced by non-physical healthcare needs, where 25% is limited to what's actually happening to somebody physically.
Thank you, Ashish. Does anybody else have a guess that you'd like to share based on your observations?
I would go 60-40 based on what we've seen. Yep.
Nice. So I think when the American Journal on Public Health came out and conducted a study, I think back in 2017, they had actually published some numbers, which I have up on the slide. Essentially, they attributed about 20% of overall health outcomes as being influenced directly by clinical care. About a third of health outcomes coming as a direct result of health behaviors and choices people make. Close to 40% from social and economic factors, and the remaining 10% from physical and environmental. So while, I mean, we're talking about health outcomes, we happen to spend so much of our time and efforts in specializing in providing care, you know, within healthcare settings. So this actually helped me quantify and really put the focus on other areas where it needs to be for us to achieve the outcomes that we're hoping to achieve. With that, JP, I'll turn it over to you. Or John, I suppose. Sorry.
Your phone may be muted.
I'll take this poll question. So the next one that I have is, what is the most predictive of an increase in hospital readmissions? I believe that's what I have. Let's start the poll and give people about a minute to answer. We're seeing answers coming in. A couple of more seconds. We'll close it out. The four options we had were education literacy, food need, transportation, and financial need. And the answers seem to be highly centered on education and literacy, and pretty evenly across the other three: food need, transportation, and financial need. So with that, John, it's on to you.
Great. Thank you so much, Krupa. And thanks for putting up that poll. Apologies, was having some technical difficulties there. So it's really interesting to see the results. We know intuitively that what's happening outside of the doctor's office is making a big impact on our ability to deliver care and drive optimal outcomes. But I think that the answer to the prior poll question brings up a really interesting conversation around what are the areas where we can focus to really drive optimal results. And so to understand kind of population effects, we wanted to be broad. And so we created a study of over 15,000 patients that CareCentrix is managing in one market in the Northeast. And our goal was to understand which of these key social determinants of health inputs are going to be most impactful and important when managing readmissions and helping to drive better healthcare outcomes. To do that, we included basically our model that covers over 42,000 zip codes and accounts for 99% of Americans and weighs each of them based on these factors. And the results were really interesting. First of all, as you see in the middle of this slide, if we think about how much of an impact broadly SDoH can make, our results demonstrated that including social determinants of health and our ability to predict readmissions made a marked difference. In general, over industry standard models and approaches of predicting readmissions such as LACE, we found that when you layer in social determinants of health data and information, you're able to be more than 10% more accurate in identifying which patients are likely to have a readmission, allowing you to really target and direct care. And specifically, when we look at kind of which of those social determinants were making the biggest impact, we really saw that it was food, and which is why I love this graphic on the screen of kind of piercing this piece of broccoli, because it's so illustrative of the importance of food in determining health outcomes. What we saw is that access to food is really 4 times as predictive of adverse health outcomes as the next closest item, which was financial need. And in particular, what we saw was that for patients with food need, those who live in a food desert or outside the range of a meal delivery service area are highly likely to have poor healthcare outcomes, and in particular, be readmitted to a hospital after an acute episode. And so as we think about the ways to best leverage our understanding of social determinants of health to drive better healthcare outcomes, we want to make sure that we're continuing to focus on the areas of greatest impact. And so as we move here to the next slide around how do social determinants of health really impact post-acute care, I wanted to just provide a little bit of background about our approach at CareCentrix and how we've seen success in improving readmissions. As you saw in the prior slide, it starts with kind of a broad-based approach of understanding the dimensions that impact a patient's health and outcomes. And from there, building a targeted program that allows us to impact those for each individual patient. So really, what our approach has been to follow the patient across the continuum, start in the hospital as they make their journey toward home, and understand the key social determinants of health needs at each of those different locations. So what we do at CareCentrix is start out with that, as we mentioned, that broad-based assessment of, based on where a patient lives and other clinical factors, what are most likely the social determinants of health needs that that patient will exhibit? And from there, how do we layer that into a really targeted conversation with patients where we ask the right questions and are able to have a dialogue around the items that would certainly not appear in a patient's claims history, but certainly are indicative of the outcomes that we're able to drive. So in our recent kind of assessment of our program, we found that in 32% of cases, so in 32% of the cases in which we're managing and engaging with patients following a discharge from an acute facility, those patients are connected to community resources based on their needs, which I think really rings true to the point that Krupa mentioned a few slides ago regarding the fact that so much of health outcomes are not driven just by clinical factors, but also by what's happening outside of the hospital or doctor's office. Of the 32% of patients for whom we're providing kind of that connection to a community resource, 75% of the time, the patient follows through and actually works to have that resource delivered to them, whether it be transportation services, food and meal delivery services, or any other type of services. What we're finding is that, as is consistent with the prior slide in terms of predictability, almost 50% of those connections are food related in terms of connection to a local food pantry or food delivery program. Around 25% of them involve transportation, and about 8% involve caregiver assistance. What we're seeing is that when we ask the right questions and we have a conversation with patients, our ability to impact and drive targeted interventions is really correlated closely with the data that we'd expect. So the results, as we're seeing, are really meaningful. And so to illustrate the results, I wanted to go through two specific patient examples, because these, I think, really point to the fact that focusing on social determinants doesn't just help in this single episode, but rather help that patient on their holistic journey for care now and in the future. So if we look at this first example, patient number one, we have a 76-year-old patient who lives in rural Kentucky. And what we find when we look at this case study is that really understanding what those likely needs are and then asking the patient through a collaborative dialogue will allow us to see things that are far beyond what we'd ever get from an EMR or from a patient's claims history. So what we found with this patient, who has COPD as well as chronic respiratory failure, was that the real barrier to the patient being able to focus on his health wasn't actually anything related to the care he was receiving in the hospital or the doctor's office. Rather, it was that the patient was spending most of his time focusing on the fact that he needed a new hot water heater tank, which was something that was significantly limiting his ability to divert financial resources as well as his time and energy towards his care process. And so what we found as part of this conversation was if we were able to connect and solve what was really the driving issue in his healthcare delivery, we'd be able to support a better outcome. And so what we did as part of our intervention was connect the patient with a social worker who found county services, identified a local home improvement program, and initiated the application that ultimately allowed for the patient to receive a new water heater tank. And I think what this demonstrates is that, in the grand scope of patient outcomes and healthcare expenditures, focusing on some of these things that are certainly not the most intuitive looking on a patient's claims, but are obviously the most impactful when you speak with the patient, are allowing us to drive outcomes and reduce this patient's return to the hospital. And the second example, before I kind of hand it off, is around another patient who really rings true with the same themes that we saw with the first patient. This was a 57-year-old woman living in an impoverished area who had hepatitis and diabetes as her primary conditions. And similarly to the first patient, what we're finding is that the real root of the patient's healthcare issues wasn't driven specifically by, just a care coordination failure in this episode. Rather, it was by, a systemic feeling of poverty and of financial need. And so, kind of through those high-level, survey data elements, we're able to incorporate as part of creating a targeted conversation and assessment for each patient. We're able to identify that this patient's challenges are really caused by, a financial need, and that the ability to gain access to insulin and required diabetes care, as well as transportation and housing, was driven by this financial need. And so as part of that, we worked to initiate the patient's Medicaid application, which will mean that in the future, the patient is able to much more easily receive access to the care and services that she needs in order to remain safe and comfortable and heal and age at home. And so this, I think, really just also points to the fact that when you focus on a connection with available community resources, started with an understanding of data as well as what's most likely for the patient, we're able to drive some really exciting results that are impactful not only on the macro side for the provider and for the payer, but also more importantly for the patient and their ability to receive the care they need on a daily basis. Great. So here I'll pass it off to Ashish for the next poll question.
Thanks, John. And I'll quickly introduce the poll here. But would love to see from the audience, when you think about social determinants, what are your biggest challenges in actually activating a social determinant of health program? Our options here are predicting and identifying patients in need, patients accepting the actual intervention and a confirmation of need, creating a referral for patients and actually driving through that staffing or placement around that particular need, and then being able to actually validate that the intervention was successful or requires additional support. So we'll take a moment for all of the responses to come in here. We're seeing a number of the responses come on through right now. And it looks like we're seeing a pretty even split between patients accepting the actual intervention or confirmation of need and then validating the impact of the actual intervention. And then next in line here is predicting and identifying the patient's need to begin with. So we'll go ahead and close out the poll, but thank you all for participating in it. I think in this next section, we're going to actually step through this entire journey. And so to get us started, Krupa, if you wouldn't mind taking us through the first point here in terms of identifying the actual need itself. We'd love to hear from you, and then I'll step in on the remaining sections.
Absolutely. Thank you, Ashish. And, it's actually heartening to see that all of us are much further along in this journey than we were even about a year ago, based on Melissa's original poll question, and to see that there are specific pain points that each of us has experienced as we've gone through this journey of actually taking this concept of social determinants and turning it into reality where we bring it to the service of patients. So that said, the 4 points that we talked about on the last slide had to do with prediction and identification, which typically translates into what's the best way for us to figure out, what the sample patient 1 that we were talking about earlier might need versus sample patient number 2. And it's all well and good if we had unlimited time and we were able to go ahead and ask every single patient a list of possibly, 50, 100, whatever number of questions. But typically when we're talking to patients, we're talking to them when they're feeling most vulnerable, possibly tired, perhaps confused or cranky based on what's going on with their health, and a whole lot of other things about their life that went into disarray because their health event happened. So it's always nice to have some sort of canary in the coal mine, so to speak. And for that, we've found that a lot of public sources of information are particularly useful. So, for example, the U.S. Census has published a whole host of information down to, sliced and diced at various levels, down to county level information. And then if we are able to take it further into census data that's potentially down to zip code level, at least that gives us an indicator in order for us to narrow those, 50 or 100 questions into the top 3 that's possibly most important to ask this particular patient in front of us Monday morning. Similarly, there's a whole host of other data sources, whether we're using chronic disease indicators or social vulnerability indices or 500 cities type data. With that said, I'll pass it back to Ashish to talk a little bit more about confirmation of need and how his work ties to that.
Thanks, Krupa. And so what I would like to do here for a few moments is to really zoom in at the individual level. I think the two vignettes that John shared were really positive stories in terms of how addressing social determinants can make a significant impact. And I think Krupa, you've touched on how do we use data to zoom in on parts or regions that could really benefit from greater interventions. Much of the work that we do at Dina is to really help organizations zoom in at the individual level in a scalable manner that allows them to identify what is the actual specific need of an individual, and then how do we actually go through the process of educating them, getting to buy-in, placement and staffing and activation, and then ultimately being able to pull data back that allows us to understand the impact of that particular intervention. At a high level, we think about this confirmation of need in four big buckets. First, really focused on an individual's social well-being, and in particular, really trying to detect if there are moments of isolation or other behavioral health issues that may be driving the overall impact on the quality of life or care for that individual. We look at things like activities of daily living. John mentioned through his research the impact of food and transportation. When we look at activities of daily living, we're really stepping into those categories. So food, transport, nutrition, and the level of independence that an individual may have in that particular category. We'll look at health and safety, and oftentimes this may be understanding your medication treatment regimen, looking at compliance around key vaccinations that could be contributing to the overall health and well-being of the individual, but also looking at something like falls. And we'll talk a little bit more about fall risk for individuals and how your home environment could perhaps be negatively impacting the ability for you to receive a great care experience. And then finally, talk about life transitions. I think all of us at some point will ultimately get to a point where the current active phase that we're in may need to transition into a different sort of model of care. So at a high level, we think about confirmation of need in these four big buckets. When we think about social well-being for a moment, studies suggest that majority of adults, 1 in 4 in particular over the age of 55, really struggle with behavioral health needs and other types of disorders. Being able to detect that, drive alignment around that, and then ultimately activating interventions around that has a huge impact on the overall cost of care as well as the outcome for the individual. And we'll talk a little bit in a few slides here around some of the numbers there. On the activities of daily living side, we know that the research shows that functional determinants, which are subsection here of social, do have a pretty strong impact on the number of readmissions on a 30-day basis. So being able to actually address issues around nutrition, bathing, grooming, personal hygiene, and then the amount of independence that somebody has a significant impact. When we look at health and safety, I want to come back to the topic here of falls. We know that every year there's over 3 million adults who are treated in emergency departments for fall injuries. And that's driving close to a $50 billion expenditure, much of which is being paid for by state Medicaid programs or by Medicare directly. There's a significant opportunity to detect whether there are home safety issues. For example, patients who are in their home transitioning from carpeted to uncarpeted surfaces, or dealing with that transition in their bathrooms from a wet to dry surface area. We know that the research has shown that those two particular sections can drive much of the risk around falls. So being able to understand that, zoom in on it, and then actually activating an evidence-based program to address that particular need is a key part of confirming that need for an individual. The last piece that I want to kind of touch on here is specifically around hospice. We know that hospice is a fantastic benefit for many, but it's not really well understood. Unfortunately, in the U.S., we're seeing length of stay fewer than 2 weeks. So people are essentially being placed on hospice way too late into their experience, and we know that Medicare funds a 60 to 90 day benefit. So there's a lot of great opportunities to help people in that phase of their life, but it's oftentimes going undetected, unable to activate the care, and ultimately drive through on the value of that particular intervention. If once we move from actually identifying the need, discussing it with the family, driving the education, oftentimes the next challenge is really making a good decision around who can actually address that particular intervention. And so what we've seen in a practical sense out there is a real challenge in trying to understand which community-based organizations or non-medical home care agencies or other organizations could actually address these social determinants. So organizing that information is a big challenge. Trying to understand what the detailed capabilities of these organizations is a challenge. How they rate from a quality perspective. So if you're an individual, how do you actually make a decision between 3 or 4 different options, in particular when, for example, Medicare doesn't necessarily rate many of these organizations today. And then coverage is often a big challenge. Does the individual's actual health plan actually include benefits that would pay or reimburse for these types of services? These are everyday challenges. One thing that we do through our platform at Dina is organize many of these organizations, take this data and bring it online to really help care coordinators make the very best decision around who can actually address these specific needs of an individual. Huge pain point in the industry. But then finally, once that actual organization is engaged, beyond that community-based organization, who's the actual individual who may be addressing this specific case? And being able to pull back data in real time around, has the individual made the appointment? Has the actual intervention started? What are the progress updates look like? So that you can actually track and improve the effectiveness of the intervention itself. We really look at this journey much more than just a directory listing, but actually how do we drive data-driven decisions around the actual intervention, and then ultimately pull back data in real time that allows us to continually start this cycle of monitoring, intervention, and ultimately helping somebody live their very best life. I want to take a moment here to talk about the impact of these interventions. So if we stick with these 4 high-level categories, and there's many other groupings that we could look at, but I want to speak to specifically the potential impact of, for example, social well-being. When we look at a study by the National Association of State Mental Health Programs, we know that there's an opportunity that when we're able to detect behavioral health issues and address those, there's an opportunity to generate a $7 ROI for every dollar spent, a significant ROI. And I think there's additional impacts beyond just the actual mental health part that actually influence other social determinants as well. When we look at activities of daily living, and specifically looking at an opportunity to activate a non-medical home care worker or a service, we know that for state Medicaid programs in particular, activating a non-medical home care service can save $38,000 on an annual basis when compared to a long-term transition to a nursing home. Significant benefit there, also one that patients and families actually prefer. When we come back to health and safety and drill down into the falls, when we look at programs like Stepping On, a program that's been backed by the CDC, that's an evidence-based program to address the issues around fall risk, we know that there's a return on investment of 64% that actually dramatically reduces the number of repeat falls by 30%. Fairly significant, especially when you look at the mortality rate for those over the age of 65 that have experienced a fall with fracture. Finally, I want to touch on hospice. And according to Health Affairs and the Journal of Palliative Medicine, we know that Medicare saves nearly $6,500 per patient when we can get patients enrolled into the hospice benefit for at least 15 to 30 days versus the less than 7 days that most patients are on hospice. These are just some examples of how others are quantifying the impact of confirming that need with the individual, driving a really evidence-based placement to somebody who can address it, but then pulling data back that allows us to really promote further interventions in a way that help people live their very best life. And with that, I'll pass this back to you, Melissa, to get us into the Q&A.
Thanks, Ashish. So I really appreciate Ashish and Krupa and John and everything that you shared today, really talking through the importance of identifying the right needs for a patient, whether that be leveraging kind of macro level at a geography level or being able to zoom in on the individual patient to identify those needs, whether they be financial, emotional, a food insecurity, a lack of transportation, poor housing, or a health and safety issue, to connect them to the best possible community resources and have a way to rate the quality of those resources, and then to look at the results and to improve the monitoring and the tracking and to improve the interventions in this consistent closed loop cycle. We really feel is critical to the the effective end-to-end management of any type of home-based program. So again, thank you all for your participation today. And with that, we will open it up to Q&A.
Thank you. Our first question: how much can social determinants of health be addressed with simple versus complex approaches to ultimately achieve machine learning?
Don't all jump at once on that one, but I'd be interested. I think that, from the perspective of some of the different things we've seen is we've really kind of elevated our own program as CareCentrix. Do you want to start there, John? And then, Ashish and Krupa definitely be interested in your thoughts as well.
Yeah, absolutely, Melissa. Thank you. One of the things that I think is really daunting for folks as we work to operationalize an understanding of the social determinants of health is the idea that everything needs to be extremely complex and perfect before we're able to gain benefits and drive improved outcomes based on the insights. And I think that one of the things we've really seen is that so many of the insights we have are really boiled down to a few headlines that drive a vast majority of the value of the intervention. So if you think about it, all of the kind of complex analytics that have gone into the development of our program really point to what we went through earlier in the presentation, which is that, food is the most important thing. And that's something that is easy to understand and identify at the macro level based on some simple publicly available data sources. And so I think that, the piece here that I would always kind of encourage folks to do, especially based on the learnings we've had as a company, is really to kind of start with the simple pieces. You can certainly spend years developing an incredibly complex model that will get you a little bit farther down the road, but it's certainly, you can certainly drive a significant impact by focusing on some of those kind of key and obvious data points.
Great, thank you. Our next question is, how do we see resources being available with the overwhelming need due to COVID-19?
Ashish, I know you and your teams have been really close to the work going on with COVID-19. Do you want to take that one?
Yeah, happy to take it. I think it's a great question. I'll take what we're seeing in a market like New York City, which has been at the center of the pandemic right now, at least here in the U.S. There's been much that has been said about activating telehealth for, primary care physicians or in the hospital or other levels of care. And I think we've seen fantastic progress in a very short period of time. But we are starting to see in places like New York City a need to actually activate remote or telehealth-like services for community-based organizations. So when you look at a market like New York City, many of those organizations that are embedded within the communities had to go offline and actually not allow people to physically enter into their facilities where most members or people would access their community-based services. And so I think what we're going to see with a post-peak operating environment for COVID-19 is actually equipping everyone to be able to participate through telehealth, including those who address many of the social determinants of health. A second thing that we saw in New York City is actual food delivery. So if you look at a number of these community-based organizations, they quickly discovered that the traditional mechanism for organizing and getting food into the community was a real challenge. So I think what you'll see is a recognition that this is a really important problem. I think some of the health equity discussions that are going on in terms of who's most impacted by COVID-19 is really going to accelerate the adoption, promotion, and addressing of social determinants, but also bringing these organizations online and equipping them with technology the same way that we do with primary care and hospital-based care is going to become a very near-term top priority.
Thank you. Our next question is, how can we leverage federal funding and legislative support for interventions directed at addressing SDoH? Anyone?
I think that is a very complex question that probably goes beyond what we have time to address today in any type of effective way.
Okay, thank you very much. I'm sure you all will follow up with that. Then our next question is, how do I get started in identifying needs and successfully utilizing social determinants of health?
I'm happy to take that question. One of the things that we're often asked about is, I think to John's earlier point, I think we can start with what's in front of us. So are we asking questions like this of individuals in terms of do they need support with nutrition? Do they need support with transportation to their appointments? Do they need support? So I think what we're seeing is staying focused on asking those questions. We do find that at every level of care, whether it be the hospital, post-acute environment, or in-home environment, that many of these types of questions are being asked. And so there are good sources of assessment data that are out there that we can tap into and then run very simple technology against to identify what the actual personalized need is for an individual. And so I would encourage all of you to look within your organizations and say, where are we documenting things that would give us a peek into an individual's social well-being, support that they may need around activities of daily living, and then additional support that we could provide on a health and safety perspective. That data is out there. I do think there is an opportunity for us to leverage what's already being captured to jumpstart addressing social determinants at scale across the country.
Ashish, a slightly different perspective there. I completely agree with what you said in terms of that data is possibly someplace within the organization, but also another place that's relatively easy to start is some of those public sources of information that we talked about earlier during the presentation, where we're able to pretty quickly down to a zip code level, get down to something along the lines of saying, if the person I'm talking to is within this age range, possibly this gender, and lives in this particular zip code, there's a high likelihood, for example, that somebody living in East LA has a high need on the transportation side and is probably not going to make it to their appointment unless I figure out a way to get them there, because the car ownership percentages in an East LA zip code are abysmal, whereas a little further away, if I look in Beverly Hills, car ownership is probably not the problem. It's going to be something else. So that even if we do not have specific information on that particular patient, there is sufficient public information that should inform us of some of these questions we can ask them. Because I think about it along the lines of, look, I'm talking to a sick person. If there are only 3 questions I can ask them before their energy or patience for me runs out, what are the top 3 questions I should be asking? And in Beverly Hills, it's probably not about transportation.
Thank you very much. Next is, what is the most impactful social determinant you've found so far?
I'm happy to take that one. So I think that this is actually a trick question. I think that, at the macro level, what we mentioned earlier is that food for a lot of patients can be very important. But at the micro level, understanding that healthcare is really personal and local, it really is, to Krupa's earlier point, an understanding of where to start and saying for each, specific geography or patient type or primary diagnosis and comorbidity, what are the most likely needs? And then from there, using conversations, using more advanced techniques to really pinpoint which of those means the most for each individual patient. Because, with healthcare, if you play too much in the averages or the macro story, you're not going to be able to kind of deliver that tailor, N=1 patient level care. And so I think that the key is to start really with a survey and understanding generally based on some of the patient's demographics or key pieces of information, what's likely to be the need. And then from there, leveraging a more in-depth conversation or assessment to be able to really pinpoint what for each individual patient will make the biggest impact.
And then how do social determinants vary by population and geography specifically?
Krupa, I think you began to touch on that with your, East LA, Beverly Hills example. Is there anything you'd want to speak to from what you've seen from kind of broader discrepancies or variations across the country?
So I think, some of the points that we've probably noticed from data just validate what we all know from common sense, right? For example, if someone is homebound and happens to live in a rural area, the transportation challenges are non-trivial. So that would be a big one. Similarly, it's quite possible that if they are homebound, they are also not able to get to the grocery store. So there's a lot of problems that get compounded and are on top of each other. Whereas if we contrast that with Ashish's example in New York City, unless the patient is at a point where they cannot literally leave their apartment or home, it is possible to get them some form of public transportation, whether it's a Metro card if they are able to get in and out of subway stations and trains safely, all the way to, arranging some sort of road transportation for them. So we do see that, there's a distinction between rural and urban. We also do see that depending on patient demographics, there might be certain distinct trends. We may also see that in patient populations where English is not necessarily the primary language, then the biggest determinant is whether they actually understand the instructions that are being given to them or the conversations that are being conducted. So really it may not even be any of these four big buckets we've been talking about. It could be as simple as making sure that there's an interpreter available.
Great, thank you very much. That is actually all of the questions we have at this time. So I want to thank our speakers for that presentation today, thank our audience, and this presentation is now over. You may disconnect.